Here's a pharmacology update. I'll be doing this live at the Nurse Practitioner Conference. This one is going to have quite a bit more in it. I would encourage you to pause it at various points and look at the various tables. In the live version, I'm probably not going to put the tables in just because I have a much more limited amount of time. But lots of interesting stuff here, I think. So first of all, declarations. Nobody's ever going to pay me to support their drug just because I think I'm too much of a cynic. Objectives, I'd like to get you thinking about cytochrome P450. I think we'll all be testing for it in the future, but we'll see. I've got way more than 3 new medications, amazing number of new medications this year. Usually I do this talk and there's 6 or 7. This time there's 20 or 30. And the category of medicines that really seems to have exploded are the monoclonal antibodies. So we'll explain those a little bit and go over those. So cytochrome P450 testing. So I think we'll all be doing this in the future. I think that we really need to understand that the medicines that are metabolized in the liver, the enzymes that metabolize them are of varying quality from person to person, to the point where some of us cannot metabolize a medicine to speak of at all, and others metabolize it much more quickly. This really does seem to explain a lot of people that their medicines wear off too quick versus others that will have substantial side effects. So this is one company that does cytochrome P450 testing. There's a bunch out there. And as I say, right now, insurances are not very good about covering that. But I do think that in the future, it is likely to become a standard. So I'm going to review a bunch of trials that are not super new, but are still very much influencing how we prescribe. The SPRINT trial, the systolic blood pressure intervention trial, got a lot of press, and it basically got a lot of press because of the recommendation of the lower the better. And basically they're saying that we should be shooting for getting people to 120 rather than the usual objective that we have of getting people to 140. A lot of things, though, that they don't mention when it's in the news. One is that the folks that were in the intensive group had almost 3 medications per patient, and the control group were actually a little bit under 2. In the control group, in the study group, there was no increase in falls, and that's the thing that they report. What they don't report, however, is that more of these people did have problems with hypotension. They did have more problems with syncope. They had problems with kidney injury. They had problems with electrolyte abnormalities, as well as some renal failure. They did stop the trial after 3.26 years just because they felt like it was showing such dramatic benefits. There does seem to be some benefits. I do think, though, that we need to think about who the trial was done on and what those benefits really are. So first, to remind you that the study group did not have any diabetics in it. Diabetics were excluded. The other thing is that they really did seem to oversample people with chronic kidney disease. People that were in the group had to have some kind of increased cardiovascular risk. This was not really a study of just people with hypertension. These were people with hypertension with another cardiovascular risk factor, either clinical, subclinical, being over 75, having chronic kidney disease. So again, I'm not sure that we can generalize this to the 45-year-old that has no other major factors. The other thing is they did oversample African Americans. Not that that's necessarily a problem, but it does question the generalizability to non-African Americans. And so you had to be over 50 to be in the study. You had to have hypertension with a blood pressure of over 130, which again is pretty limited, I think. And you had to have one of these risk factors for heart disease, either clinical, subclinical, chronic kidney disease, a Framingham 10-year risk of greater than 15%, or be over 75. So the exclusion criteria, if somebody had secondary hypertension, if they had, known proteinuria, if they had other kidney issues such as polycystic kidney disease, a history of stroke, but most notably, they did not have diabetics in this study. They specifically excluded them, mostly because diabetics had already been studied in the ACCORD trial, and there really was not a whole lot of benefit for them. We'll talk about that in a minute. So here's the actual chart when we look at the outcomes for the SPRINT study. Interestingly, there was not any decrease in heart attacks. The ones in green here are the ones that were non-significant. The ones in yellow were the ones that had significant benefit. Now the primary outcome, this is one of my pet peeves, and just to sort of explain why. The primary outcome was anybody with a first occurrence of an MI, acute coronary syndrome, stroke, heart failure, or death from cardiovascular causes. The problem is that when we controlled for all of the other variables, 3 or 4 of these actually fell out as being non-significant. So it infers that in the primary outcome that it has benefit for all of these things. In fact, it doesn't. It just has benefit for that pool of things, and you need to look at the sub-analysis to look at whether or not there was any benefit for that specific issue. So no benefit for MI, no benefit for coronary syndrome, no benefit for stroke. There was benefit from heart failure as well as overall death from any cause. Interestingly, 3.26 years is not a lot of time to see a benefit for heart failure. So it's interesting, and it's a question that I think has to be asked about their sample. The other thing that's not mentioned much is that the people without chronic kidney disease actually had greater than a 30% reduction in their GFR at a rate of 3.8% versus the control group that only had 1.1%. So I think this is important to remember. The medicines that these people on may have actually caused damage to their kidneys. So for me, it does bring into question this assumption that the lower the better. This is the slide I'm going to use for the presentation. It basically summarizes the things that we just talked about. And just to remember, the ACCORD study in SPRINT, we did show a relative reduction of this pooled outcome. In ACCORD, we only showed a 12% relative reduction, one, because there weren't as many things in the pooled outcome, and two, because it was diabetics, we really did not see the benefit that we had expected to see. There was a mild non-significant difference in reduction, but the general feeling is that for diabetics that there is no evidence for the lower the better. Low-dose rivaroxaban, I'm going to talk about NOACs again in a later presentation, but just to talk about this because it has come up lately, there's a lot of patients that I'm seeing that are on 2.5 milligrams of rivaroxaban after a stroke. It does seem to decrease stroke. The problem is that there are some increased bleeding issues, including fatal hemorrhage. This is the actual data on it. We see that the folks with ischemic strokes went from 5.7% in the aspirin alone group to down to 4.3% in the rivaroxaban plus aspirin. So that's an absolute risk reduction of about a 1.5. The hemorrhagic stroke, interestingly, also went down a little bit. There were not a whole lot of other benefits that were seen. The bleeding events, however, did go up with people. Aspirin alone, for example, in major bleeding, 1.9% versus 3.1% in the rivaroxaban plus aspirin group. You can look at each one of these. A number of different areas had increase in bleeding, but as you can see, the absolute risk rate was not dramatic in any of them. So cholesterol lowering. When you have somebody that has elevated lipids, there's a whole bunch of different guidelines out there, and it's really hard to decide who to follow for guidelines. Do you follow the 2018 guidelines? Do you follow the European guidelines? Do you follow the endocrinology guidelines for diabetics? What guidelines do you follow? I don't really have a good answer for you. I will tell you, though, that the guidelines in the United States have really moved away from any sort of lifestyle intervention. Basically, if you've got somebody that has enough risk factors, they are recommending that if you're going to treat them, that you treat them with a medication. On the left-hand side of this chart is the majority of patients that we see that have an LDL between 70 and 189. That are between 40 and 75, and they're basically saying if you compute their 10-year risk and they've got more than a 7.5% risk of heart attack or stroke, that you put them on a moderate intensity statin. The Europeans are still more conservative. Not sure who's right, hard to tell, but as I say, the standard right now is to use more of a statin. Also to just remind you that most of the people in this situation, if they don't have clinical coronary heart disease, and you're looking on the right-hand side, or I'm sorry, the right-hand side of this chart at primary prevention in the people that are 70 to 189, the majority of these people are not going to be candidates for any sort of unusual medicines such as a PCSK-9. Basically, these patients are just going to get statins. It's only in those people who have a dramatically high LDLs or have previously had a heart attack. In my opinion, the PCSK9s are really medicines that should be reserved for cardiologists to use. I don't really see myself using them at all. But each of us has to make those own choices, don't we? So just to review the PCSK9s, so basically PCSK stands for proprotein convertase subtilisin kexin 9. It basically is a substance which is involved in the production of cholesterol. The Fourier study looked at whether or not by inhibiting this enzyme that we could decrease LDLs and therefore decrease heart attacks, strokes, and deaths. The results of that are shown in this table. Again, they did a couple of these cumulative endpoints. They were both significant. However, when we look down below, we see that there was no real benefit for myocardial infarction. There was no benefit for death from any cause. There was benefit from MI, but of course, if there wasn't any for deadly MI, these are non-fatal MIs. No benefit for a hospitalization for unstable angina. There was a benefit for stroke. There was a benefit for having to go to the vascular lab. And there was no benefit for heart failure. So really it does show that there is a benefit for non-fatal MIs and for stroke. Does not seem to save any lives. Did not decrease cardiovascular deaths. Did not decrease death from any cause. So this basically just summarizes that. I'd really like you to look at this slide because in a minute we're going to talk about Zetia. And really the benefits of Zetia are almost identical to the benefits of Repatha. Repatha is substantially more expensive than Zetia at this point, but they both are medicines that are used in conjunction with a statin rather than trying to replace a statin. Because again, statins are the only medicines that have really been shown to have any benefit as far as cardiovascular death reduction and overall death reduction. So here's the Zetia. Zetia works by working on a particular enzyme, the NPC1L1 enzyme. It basically was studied in the Improve It trial, which was published in the New England Journal in 2015. The data was 7 years, and so again, this is really only in people for secondary prevention. There is no real data on primary prevention. So these are people that have had a heart attack. The Repatha data is the same thing. There is no data on primary prevention. So here's the Zetia data. Interestingly, almost identical to the Repatha data. Some benefit for stroke, some benefit for non-fatal MI, no benefit from cardiovascular death, and no benefit from death from any cause. And as I say, this slide is almost identical. So I think that in my mind, if you're going to add a medicine to a statin, the Zetia is probably as good or better than doing the Repatha at this point. The Bempedoic Acid has been in the news lately. Basically, this is a medicine that unfortunately NBC News was telling people might be able to replace statins. I think that's way premature because there's no data at all on cardiovascular or overall mortality. It basically uses the same pathway that the statins use, but it's a couple of steps upstream from the mechanism of action of the statins. Stay tuned for this one, but I'm not impressed. Aspirin for primary prevention. We've got 1,000 patients asking us about this. In fact, the data does seem to suggest that the aspirin is probably more risky than helpful for primary prevention. A question that I'm getting fairly often is from diabetics, of course, just because there is another study. The study that looked at aspirin in diabetics was the Ascend study. It did seem to show some benefit. So I'm actually leaving my diabetics on aspirin at this point, but they are going to be asking about the studies, and you do need to be ready to discuss that. So looking at that aspirin study, we do see the most interesting thing to me was that the all-cause mortality was actually slightly higher in the aspirin group. There was a decreased risk of cardiovascular disease, 10.7 events versus 11.1 in the placebo group. But the amount of bleeding was actually, notably more in a number of the other outcome measures. So fish oil, just to sort of finalize on the cholesterol thing, there was a study that recently came out. We know that the studies that have been on fish oil really show no benefit as far as cardiovascular mortality, and that most of the cardiologists have really told people they don't need to be on it. I do think it still has benefit for preventing pancreatitis in people with triglycerides over 300 or so, but that's a different discussion. Folks in this study, the Bott et al. Study, they called it the Reduce It study, went on for about 5 years. They basically used a sort of a purified version of the fish oil. They took something called icosapent ethyl out of it, made it into a medicine called Vascepa. And the outcomes for Vascepa were actually pretty good. The death from any cause did not reach statistical significance, although it was trending in that direction. Cardiovascular death, again, just barely was statistically significant. But most of the other outcomes in regards to heart attacks, strokes, and others. So it did seem to have some fairly good evidence. The data is one thing, of course, and it's hard to tell whether we'll really see these outcomes, but other than the cost, there is, I think, some real evidence for this particular medication. All right, that ends part 1. We'll go on to part 2.